speaker. It's my pleasure to introduce Lisa Carey from North Carolina Medical School, identifying research priorities in prediction of response in patients with early breast cancer.
Thank you, everyone. It's a real pleasure to be here and to try and synthesize the session. So I'm going to first point out the obvious, which is we have to differentiate prognostic features of the cancer, those things that confer the natural history of the cancer regardless of therapy, from predictive factors, which is the topic today, which really confer impact on outcome via their impact on treatment response. So yesterday was a discussion about prognostic features, which are hugely important and keep coming back into these conversations. But I'm going to talk about the second bullet, which is really the predictive factors today. Not going to talk about novel therapeutics because until we know whether they have value themselves, it doesn't matter in the early breast cancer setting about whether there's a predictive factor for them. So if you need to leave, the research priorities that I'm going to identify are really two. Identifying response-relevant biology for de-escalation, and then optimizing and using the neoadjuvant setting for tailored and escalation of therapy. So those of you who need to use the restroom can leave now. So let me put a little more information, granularity to that. So if we think about the early breast cancer decision-making process that we have typically anatomic features and biologic features. Anatomic features, obviously tumor size, nodal status are the classic ones. Biologic features historically were grade hormone receptors HER2 and now increasingly genomic assays. Anatomic features are largely prognostic factors. They really don't have an impact independently on response to therapy. Conversely, biologic features can be both prognostic and predictive. So I'm going to make a sort of important, I think, caveat as we're going to be talking about predictive features over and over again, which is, here's an example from the clinic, 40-year-old otherwise healthy woman with a 0.2 millimeter node negative, potentially high grade. I'm not giving you the receptors because it's not relevant. If the natural history of the disease, if the prognosis of the disease is excellent, response to therapy is not relevant. Now, we are the beneficiaries of really good impact through prediction in all the subtypes of breast cancer, and these are highlighted here from these curves of the natural outcome in breast cancer from the British Columbia Registry from 1980s into the early 90s versus the early part of the 2000s, and you can see in every clinical subset of breast cancer, outcomes are better. Chemotherapy is better, the way we give chemotherapy is better, endocrine therapy is better, anti-HER2 therapy, et cetera. So our goals historically were to reduce mortality, and that was pretty much the overarching one when patients had a 60% cause-specific mortality. Now the goals are to tailor therapy and don't overtreat, which is why this session is so important. So let's break it down by the different subsets as were outlined beautifully by the previous speakers. So the first is HER2-positive breast cancer. It comprises about 15% of incident cases. It's aggressive without therapy. We all know this. But now we have multiple very effective and approved regimens. But this is part of our complication, right? So these are the neoadjuvant regimens in HER2-positive breast cancer. If you were to summarize all of them, essentially it's a lot of chemotherapy and potentially a lot of anti-HER2 therapy in everyone but the lowest clinical risk. Now we've learned from the APT regimen, which I think is a great paradigm for the future. In this case, the APT de-escalated regimen took clinical low-risk HER2-positive breast cancer, about 400 patients. It was not a randomized study. The patients all received a very simple regimen, one chemo drug, one anti-HER2 drug, and you can see that at 7 years, the point estimate for disease-free survival is still well above 90%. So the question is, how do you duplicate this success in higher clinical risk cancers? So the neoadjuvant strategy, as everyone knows, has been a very good one for trying to get a handle on highly responsive tumors versus less responsive tumors to our conventional therapy. And this is, of course, from the Cortazar meta-analysis demonstrating that PCR is a good intermediate biomarker. And I say good deliberately because, as you can see, there's quite a few patients with PCRs who do relapse. It's also true that the residual disease patients, many of them do not relapse. And moreover, the relationship of PCR to event-free survival is not clean. And in many otherwise very similar trials, you can see pathologic complete response rate patients with an 80%, a 90%, a 95% event-free survival without a clear reason for there being that difference. So I'm going to call this the cheap way of identifying highly HER2-responsive tumors, which is through the neoadjuvant administration of conventional therapy. It doesn't cost you anything to just ask your pathologist to tell you whether you have PCR or not. So this was CALGB, which is one of a number of trials that Aleix Pratt outlined. And you can see in the pathologic complete response patients, there was above a 90% 5-year event-free survival with just paclitaxel, trastuzumab with or without lapatinib. And this was true whether the patients were clinically hormone receptor positive or negative. So what if you were to omit the chemotherapy altogether? And Aleix also outlined this. If we want to get to de-escalation, and I think most of our patients would prefer our de-escalation is to get rid of chemotherapy and just identify patients that are hypersensitive to HER2 targeting, here's a variety of trials in which clearly unfortunately, small subset of patients have pathologic complete response to an all-biologic regimen, only HER2 targeting, no chemotherapy. Now, the problem is the response is highly variable, and in truth, it does seem to matter how long you treat for. So pathologic complete response is higher, and I'm not showing this, but in adjuvant studies, the outcome seems to be better in longer therapy. As Aleix outlined, we may be able to get smarter about both duration and who can omit chemotherapy, but it's going to take some work. So what about predictors of response, the not cheap way, the scientific way? And this is just one slide to outline what Alex already did, outlined beautifully in his talk, which is you can see the effect on pathologic complete response as well as event-free survival simply through molecular subtype of the tumor. And then on the right, I'm showing you the multivariable analysis of the event-free survival in CALGB 40601, which demonstrated that treatment arm mattered. Dual therapy had an improved outcome in this study, which is not seen in all of them, on event-free survival. But so did pathologic complete response with the same hazard ratio that was seen previously. Also immune activation. In this case, it was done by RNA signatures, but this is where TILs also plays a role. These are independent of each other. And then finally, subtype, particularly luminal A versus luminal B within the hormone receptor positive. These factors were also predictive. So intrinsic subtype and evidence of immune activation were also significantly associated with pathologic complete response. So I would argue that for us to get smarter, we need to measure these variables in real time in our trials in order to understand drug response. Now, we do have a good problem, but a problem that's going to be highlighted in both this and the triple negative subset, which is the residual disease therapies means that interpreting neoadjuvant trials just got harder. So what's shown here is the Catherine trial. So now the residual disease component in that setting, in HER2-positive disease with residual cancer after chemotherapy and trastuzumab, got either TDM1, the antibody-drug conjugate, or continued trastuzumab. And as you can see in the Kaplan-Meier curve, it was highly more effective to give TDM1 than to continue trastuzumab in these patients with residual disease. It was very effective. It's more expensive. It is clearly more toxic. But this is now a new way of approaching escalating and de-escalating therapy. Now let me change my focus to triple negative, and you'll see there's some overlaps, at least conceptually, with the approach. So of course, this is again about 15% of tumors. The challenges are that they remain our poorest prognosis group. It's also molecularly heterogeneous, and our treatment options in the early breast cancer setting are limited to chemo. This is sort of a grouping of different ways of looking at the heterogeneity of triple-negative breast cancer, which I have in quotations because, as Karsten just demonstrated, it really isn't a biologic entity. It's a grab bag of things that is not. It can be histologically heterogeneous, which can be prognostic, as many of you know, but not really predictive for drug response. It's also molecularly heterogeneous from the standpoint of intrinsic and other subtypes, but it's unclear how to make those actionable from the standpoint of treatment. And then, of course, the evidence of tumor-infiltrating lymphocytes and immune activation is mostly prognostic, although there is a predictive element. Now, what are our advances? We actually haven't made big advances in early breast cancer therapy for triple-negative disease. As you can see, the regimens are polychemotherapy-based. They remain polychemotherapy-based. I show you on the bottom the ABC trials, exploratory analysis within a hormone receptor subset, and the triple-negative subset looking at anthracycline added to a taxane. Actually, you see a proportional benefit is there in triple negative. It doesn't seem to matter how many nodes are involved, although the absolute benefit is far lower in node negative because the absolute risk is lower. But the neoadjuvant setting does help us be a little bit more thoughtful to a limited degree. So in triple negative, because the neoadjuvant setting, typically you're giving all of the drugs that you were going to, at least historically, pathologic complete response is, of course, highly associated with a better outcome than residual disease, which is particularly bad in triple negative. But now we have the same problem, again, a good problem to have because this is thoughtful, rational escalation, but it does make it complex for interpreting neoadjuvant trials, which is that now you are compensating for residual disease and poor responsiveness to conventional drugs by intervening with a new drug in the adjuvant setting. This is CREATE-X. In which residual disease, HER2-negative breast cancers were treated with either capecitabine or not, and it was an overall positive trial, and the results were driven by the triple-negative subset within the trial as shown on the bottom. Both disease-free survival and overall survival substantially improved in the absolute sense by the addition of capecitabine. This is a very popular approach for trials now because it identifies a high-risk subset and it allows you to tailor the approach. I'm showing you here just in the cooperative group setting in the United States in triple-negative breast cancer, there are 2 studies using the residual disease approach, one looking at CAPE versus carbo, the other looking at an immune checkpoint inhibitor. But I'm going to point out to you something that's very important. Residual disease trials are just high-risk adjuvant trials. They have the same issues as other adjuvant trials. You just have a high event rate. So here's our opportunity, and part of the research priorities, I would say, is how to non-invasively identify residual disease so that you can actually continue this escalation and tailoring without losing the opportunity for tissue correlates. And then finally, hormone receptor positive, HER2-negative breast cancer, the majority of our tumors. Matt Ellis gave a beautiful delineation of the biology of this. I'm going to say when you take a step back into the clinic and to the tools that we have available to us, remember that one of the nice things about gene expression-based analyses is that the genes that are related to endocrine sensitivity tend to be inverse to those related to chemosensitivity. So many of our advances have leveraged both identifying high hormone receptor targeted sensitivity and using chemotherapy in those that are low for that. So, this came up yesterday, and I think it's worth noting. This is the challenge that we have right now. Is again, 40-year-old woman with a 7.5 centimeters. Actually, a patient from my own clinic, 7.5 centimeters, 5 involved lymph nodes, grade 2 or Ki67 is kind of moderate. Hormone receptor strongly positive, HER2 negative. Do we actually have the tools to tailor in this setting? And I would say no, although I hope that we will in the future. So now, what about PCR? So PCR is agnostic to subtype. PCR matters no matter what subtype you're treating. The problem is, while it is meaningful, it's rare in hormone receptor positive HER2-negative breast cancer, as is shown here. It is meaningful, but it's only 10% of the population with either chemotherapy or endocrine therapy. Matt showed his ACOSOG Z1031 data, which was a lovely demonstration of the potential for using a pharmacodynamic, because remember, PEPI, it's tumor size, nodal status, so it's anatomic elements, but it also has, particularly driven by post-therapy Ki67. So it has a pharmacodynamic element to it, which I think makes it quite appealing, and this may be the way forward. This actually has not yet been validated, but is in the process of being validated in a large study called Alternate that is about to complete accrual. So hopefully the PEPI will become part of our normal use in the future. So what about chemotherapy? So response to chemotherapy in hormone receptor positive HER2-negative breast cancer, it's been tested prospectively in 2 large, wonderfully performed trials, MIND-ACT and TAILOR-X, and essentially found no apparent chemotherapy benefit in mammoprint low or intermediate recurrence scores overall. These studies did not address endocrine responsiveness. Here's the problem is, of course, that you can say that response to or need for chemotherapy and outcome was tested. Maybe more need for than response to. The MIND-ACT and TAILOR-X both are in, even their clinical high-risk groups for MIND-ACT was actually relatively low risk. If you consider the patient I outlined before, the high-risk arm, less than 10% were T3, less than 20% had more than one involved lymph node. No arm had a distant metastasis-free survival worse than 90%. In TAILOR-X was largely a stage 1 population that was tested, and even their worst group had an 87% distant metastasis-free survival, even though they were treated with both chemotherapy and endocrine therapy. Now, I do think these gene expression assays are, in fact, prognostic and predictive. And you can see here, this is a Danish cohort. This is the Prosigna score. There are very similar studies in lots of different, using lots of different assays. Couple of caveats. So this is a Danish cohort treated only with endocrine therapy. Mostly, the node-positive group was mostly one involved lymph node. And if you get to more than one involved lymph node, in fact, in this case, I think in the 3 involved lymph nodes, there were 0 low scores. They're certainly very low. And that's true in a lot of these. So you have to kind of decide, going back to my stage 3 patient, how much of a believer are you? Because the question here is, are you going to omit chemotherapy? And I would argue we're getting there, but it's pretty hard to argue in these very high-risk clinical risk patients. And a couple of data that have come out that, again, give you more of this pause. We have to be a little careful. This is a large registry, but is a registry. This is not a randomized controlled trial from the National Cancer Database. About 12,000 node-positive breast cancer patients with intermediate recurrence scores, and you can see a little bit of a variation in terms of the benefit of chemotherapy in patients that were node-negative versus node-positive in the upper left. And if you do the modeling, you start to see a little bit of a variation. Treatment benefit is affected by both biology and underlying risk. It's easier to see a marginal improvement once the risk goes up, so I would call this uncertainty. And then finally, late distant relapse. Ivana showed a beautiful analysis of the trans-ATAC across a variety of assays. It's very key that the clinical elements drive a lot of what happens with late distant relapse. These are dominant, particularly in the node positive, and are mostly prognostic. But we do have a little bit of data, and I think many of us genuinely believe that this kind of late relapse identification of patients at risk for it can be intervened, and in fact, some data suggests that there's a predictive element. This was a late relapse group of patients from MA17. This is a case control study in which some patients got letrozole and the control received placebo, and you can see essentially using the BCI, or at least the ratio part of the BCI, the addition of the aromatase inhibitor seemed to normalize the risk in terms of outcome. So to summarize, the research priorities, I would argue, routine real-time incorporation of tumor biologic assessments into therapeutic trials. I would include both tumor and immune microenvironmental factors need to be done. We need algorithms that both incorporate anatomic and biologic data. They cannot be treated separately in order to determine both risk and prediction. And then I would say that in order to get better with neoadjuvant therapy, which we are increasingly using routinely for clinical reasons as well as research, we need to identify residual disease without, say, sending the patient to surgery. Thank you.
We have time for a couple of questions. Okay, it looks like it's time for the coffee break. We'll be back at 10:30.